we're going to start the next section of material. The material that will be covered on the next test includes pulmonary pathophysiology, renal pathophysiology, and GI pathophysiology. I believe that's what the syllabus says. So sometime within the next 5 sessions or so, we need to cover all of that material. So we'll try and cover as much of the pulmonary material today as we can. Before we do, does anybody have any questions about how the course is going, or any comments? Yeah.
So it seems like GI pathology will be divided into tests.
What's that?
The GI, because according to the syllabus, it seems that GI pathology might be divided into tests. Is that your?
No, that wouldn't be the plan. So how many GI lectures are there?
So we have one before the test.
There's just one on this.
There's only one listed for the next exam.
So it's tested on the next exam?
Yeah.
All right, so pulmonary and renal are tested on this exam. The GI is tested on the next exam?
Yes.
All right, so that's the way it'll work. But I think the lecture comes before,
There's one lecture.
GI comes before the next exam. Okay. All right. All right, so let's go ahead. Any other questions? All right, so let's go ahead and start with pulmonary. Okay, so the lungs, as you know from physiology, their physiologic role is the oxygenation of the blood and the getting rid of carbon dioxide from the blood, and they do this. This is the anatomical structures that are responsible for it. You know that gas exchange takes place in the respiratory zone, so including the respiratory bronchioles, the alveolar ducts, and the alveolar sacs. All of these structures contain alveoli, and that's where the heavy lifting of gas exchange takes place. Okay. So what we're going to talk. You'll see that this graph depicts the location of airway resistance. Airways are tubes just like the blood vessels are, so you remember the relationship between flow and pressure and resistance. And you see that most of the resistance occurs in the bronchioles, at the level of the bronchioles. And even though the airways that are distal to the bronchioles have a smaller caliber, they're responsible for a very small fraction of the resistance because the total cross-sectional area is so great. You see that the total cross-sectional area goes up as you go from the conducting zone, so the trachea down here, you go to the respiratory zone. If you lay the alveoli out on a flat surface, it's a tremendous surface area compared to the cross-sectional area of the trachea. That's what this slide is depicting. And then this is, again, just to refresh your recollection from respiratory physiology, this references the different volumes that we refer to when we're talking about pulmonary function and when we're talking about pulmonary function tests. So it's just there for your to consult it. Let's talk about some, since the lungs are responsible for the getting rid of the elimination of carbon dioxide and for the oxygenation of the blood. So the things that can go wrong, with lung disease are going to include hypercarbia, or carbon dioxide that's too high, and hypoxia. So let's talk first about hypoxia and some of the things that can produce hypoxemia. Okay, the 6 causes of hypoxemia include, first, VQ mismatch or ventilation perfusion mismatch. We're going to talk about that in a second. Second, intrapulmonary shunts. Third, hypoventilation. Fourth, diffusion abnormalities. Fifth, a decreased FiO2, a fraction of inspired oxygen. And then sixth, increased venous desaturation. We're going to talk about all of these. So let's talk first about VQ mismatch. This represents, of course, an alveolus, and this represents an alveolar capillary, okay? And what they're showing here is that the size of this relative to the size of this is supposed to depict balance. So we have appropriate ventilation for perfusion in that area of the lung, okay? You have just the right amount of blood and just the right amount of air, okay? That's in the normal situation. You have matching of ventilation and perfusion, VQ match, okay? So with VQ mismatch, there's a couple of different possibilities, okay? And you'll see these are two ends of an extreme, okay? But they depict, at one end, dead space, which means that you have ventilation but no perfusion. If you send air to an area of the lungs where there's no ventilation, that's wasted ventilation. Where there's no perfusion, that's wasted ventilation. Okay, that's called dead space. At the other extreme, you have a shunt, okay? What that means is that you're sending blood to an area of the lung where no air is reaching, which is not being ventilated, okay? So these are the two extremes, dead space and shunt, okay? So one of the things that might produce this, as you'll see, would be a pulmonary embolism, where we'll show that to you in a subsequent slide. And this, if you have complete airway obstruction and atelectasis, you'll produce this situation, okay? In the middle, you have VQ mismatch. You have a deviation from this situation here. Here you have inadequate ventilation for the amount of perfusion in that area of the lung. And here you have inadequate perfusion for the amount of ventilation in that area of the lung. So VQ mismatch is the first cause of hypoxemia that we were talking about. Okay, here's again the normal. Here is the normal situation. The shunt that we talked about, remember, we said if you have complete airway obstruction, you have no ventilation coming to this area of the lung. If perfusion continues, then you have a shunt, okay? And that would be an example of an intrapulmonary shunt, which is the second cause that I gave you. Pulmonary embolism, again, you have complete occlusion of the perfusion to this area of the lung, ongoing ventilation, and that's physiologic. That is dead space. The third cause of hypoxemia is hypoventilation. Okay. So if I give somebody a whopping dose of morphine and their respiratory rate goes from 15 to 1, then what am I going to see? I'm going to see the CO2 is going to rise and the O2 is going to fall. And the O2 is falling because they're only breathing one time a minute. Okay? Hypoventilation, unlike some of the other causes of hypoxemia, is associated with a normal AA gradient. And we're going to talk about the AA gradient in a second. Okay? Diffusion abnormalities. You see that where the alveolus and the capillary come into proximity with each other, that membrane is very thin, okay? And so the oxygen and the CO2 are able to diffuse across that membrane without any problem at all. But if you get thickening of this membrane for some reason, like for example, if you have fluid in the interstitium over here because of congestive heart failure, or if you have thickening because of fibrosis, then you're going to be dealing with a diffuse, or if you destroy large segments of the interstitium of the lung, like with emphysema, then you can develop diffusion abnormalities, and we'll talk about that. The fifth cause of hypoxemia was a decreased FiO2, and that's big F, little I, O2. It's the fraction of inspired oxygen. So the normal fraction of inspired oxygen is 21%, because room air is 21% oxygen. So if I put one of you guys in a room and I start sucking the oxygen out of it and increasing the oxygen, the nitrogen content of it, I decrease the oxygen percent to 10%, then your blood gas oxygen is going to go down. Okay, and again, that's going to reflect a change in the FiO2 as opposed to any pathological process. You can also see things like that at high altitude, okay, where the partial pressure of oxygen goes down as with increasing altitude. And then finally, the last cause of hypoxemia is increased venous desaturation. So you can sometimes see this in patients who are septic, and they have tremendous oxygen debt, and the peripheral tissues are sucking every bit of oxygen out of the arterial blood that they can. And so the venous blood that's returning to the heart, instead of returning at, I'm just going to make a number up, I don't even remember what it is, but let's say it's supposed to be 75% saturated, it's returning at 50% saturated. So if you're starting from a lower baseline, it's going to be harder to oxygenate that back up to a normal level, and so that can be a cause of hypoxemia. It's increased venous desaturation. Okay. Any questions about that before we talk about the AA gradient, which I alluded to, and how these things relate to each other numerically? Any questions about? Yeah, go ahead.
What was the second?
What was what?
What was the second cause?
DQ mismatch, intrapulmonary shunt. Okay, so let's talk about the AA gradient. Okay, so the big A stands for the alveolar oxygen gradient, alveolar oxygen, and the little a is going to stand for the artery. Okay, so alveolus and artery. So this is the oxygen gradient between the alveolus and the artery. Okay. So the arterial oxygen you measure on a blood gas. So you insert the needle into usually the radial artery. You get a blood gas sample. You inject it into the machine, and it tells you what the PO2 is in the arterial blood. pH, PO2, PCO2. It gives you the blood gas. Okay. So we can get this from the patient by drawing arterial blood. The question is, how do you measure the alveolar oxygen? Well, you have to calculate it, okay? And so the way you calculate it is as follows. The partial pressure of oxygen in the alveolus, okay, is going to equal to the FiO2, which is the fraction of the inspired oxygen that the patient's breathing. This will get simpler in a second. This is 760 millimeters of mercury, which is atmospheric pressure minus 47, which is, I guess, water vapor. All of that minus the PaCO2. So this is the CO2 in the arterial blood. Again, you're getting that off of the divided by 0.8, which is the respiratory quotient, which is the ratio of CO2 production to O2 consumption. So again, do you need to have it this complicated? Most of the time, we're dealing with people at sea level, atmospheric pressure, so you can simplify it, okay? And the FiO2, okay, it really depends on if you're breathing room air, it's 0.21, okay? This may change if you have somebody on, let's say, a face mask or something like 28% face mask or whatever. But if you're dealing with somebody that's breathing room air at sea level, okay, then this is 0.21, and then 760 minus 47 is what, 713? So 0.21, it works out to about 150 or something, is that right? 0.21 times that, is that right? 147 or 150? Somebody do that?
That's about it.
Huh?
That's about it.
What is it?
Around 150 or 147.
Okay, 150 minus the PaCO2, whatever the PaCO2 is, divided by 0.8. Okay. So you plug the number that you get from the blood gas into that. Okay. So let's say that you have somebody that has a PCO2 of 40. Okay. So 40 divided by 0.8 is 50. Okay. So this would work out to an alveolar oxygen of, let's say, 100 in that situation. Okay. So to get now you have this one you're going to get off of the blood gas. Okay. This one you're going to get off of the blood gas. So you might have a PaO2, whatever, 80, 90, whatever. The AA gradient is the difference. It's the alveolar minus the arterial. The difference between those two. So let's say it would be 100 minus, let's say, 85. 100 minus 85, the AA gradient would be 15. Okay? Everybody see that? Okay. So then the question is, well, is that good or not? Okay? And so what you then do is you compare your calculated AA gradient to your expected AA gradient. And there's two ways to calculate an expected AA gradient, okay? One way is a normal AA gradient. An expected AA gradient, a normal AA gradient, is equal to the age of the patient plus 10. That's the numerator, the age of the patient plus 10, divided by 4. So let's say our patient is 89. We've got to make it easier than that, right? Let's say it's 80. Patient is 80. Okay? The age of the patient, actually, let's make it easier than that. The patient is 70. Okay? Plus 10 is 80. Divided by 4 is equal to 20. So for a 70-year-old patient, the expected AA gradient is about 20. Okay? So if we get an AA gradient that's 15, we just said it was 15, right? We'd say it's normal because it's less than the expected AA gradient, right? Everybody see that? If you don't see it, say so. Okay? All right. That's one way to calculate. Yes, go ahead.
I'm sorry, would you mind going over the last bit of the AA gradient where you actually calculated the FiO2 just one more time?
The FiO2 is, you don't calculate the FiO2.
Oh, no, I'm sorry, like just from that point on after you calculated that. I'm sorry, I missed it. I just didn't.
Okay, so the FiO2 you know because you know what the patient's breathing.
Yes.
Okay? And then we usually, if we're dealing with a patient breathing room air at sea level, we can just simplify this whole thing to it's 150 minus PaCO2 divided by 0.8. Okay?
That's the point of it, sir, is the PaCO2.
This you get from the blood gas.
Okay, and then just
You get-
divide it
you
by
plug that in.
Yeah, okay.
All right?
All right.
The second formula that you can use, besides age plus 10 numerator divided by 4 in the denominator, the other way you can calculate it is the age in the numerator divided by 4 in the denominator, okay? You take that whole, whatever that gives you, and you add 4 to it. So if we want to use the same patient and use the other formula, it would be the age is what, 80? 70. She was 70. Okay. So age of 70 divided by 4 is what? 16?
17.
Huh?
17.5.
What's that?
17.5.
Okay, 17.5. And add 4, so you add up to 21.5. So it's essentially the same thing. They're gonna spit out essentially the same number. Doesn't matter. Just remember one of them. Age plus 10 in the numerator divided by 4, or age divided by 4 plus 4. Right? Go ahead.
So the number you all expected is fine.
Yeah, if it's less than you expect, then that's good. If it's significantly above that, then that means that the AA gradient is lower than you would expect. Okay? And that the AA gradient is, if the number's above that, then you say the AA gradient is higher than you expect, and that means you have a problem with gas exchange. Okay? So let's go back and just look quickly at the causes of hypoxemia. VQ mismatch is going to cause a change in the AA gradient. Intrapulmonary shunt is going to cause a change in the AA gradient. Is hypoventilation going to cause a change in the AA gradient? I already told you it wouldn't. Why not? Why doesn't it cause a change in the AA gradient?
You're not bringing any oxygen anyway.
What's that?
You're not bringing any oxygen in the alveoli anyway, so that's going to be.
Well, but yes, but why? But that's true of a lot of things. But why not? Oh, okay. Go ahead. So, go ahead. I see where you're going. Go ahead. Say it.
Yeah, so you're not bringing any oxygen in. So if you're not bringing any oxygen, you're.
Yeah, the oxygen in the alveolus is going to be low, just like the oxygen in the blood is low. See, the AA gradient means that if you have a high AA gradient, it means that the oxygen in the alveolus is high, and the oxygen in the artery is low. That's an AA gradient. Whereas with hypoventilation, they're both low. Okay, same thing with decreased FiO2, right? If you have a decreased FiO2, they're both going to go down. The arterial and the alveolar oxygen. So decreased FiO2 and hypoventilation are going to produce a hypoxemia with a normal AA gradient. That's important. Okay, that's because you want to be able to figure out why your patient is hypoxic. If they're hypoventilating, the approach is going to be completely different than if they have lung disease. So let's talk just briefly about the approach to the patient that has hypoxemia. If you have a patient that presents with hypoxemia, what you want to do is you want to look, so you're going to see that from the blood gas, okay? What you want to do is you want to look next at the PCO2, okay? If the PCO2 is increased, PaCO2, the arterial CO2 is increased, then what does that tell you about the etiology of the hypoxemia? Remember, the hypoxemia could be a VQ mismatch, it could be a shunt. So what is it if you see an elevation of the PaCO2 compared to normal? What does that tell you about the cause of the hypoxemia?
Hypoventilation.
Yeah, it says that there's an element of hypoventilation that's present. Okay, now, just because somebody's hypoventilating doesn't mean that that's the only cause of their hypoxemia. Because if I take somebody with, let's say, congestive heart failure and pulmonary edema, right? So they're going to have other reasons to have hypoxemia. But at some point in time, if they start to fatigue and they develop respiratory failure, then they'll develop an element of hypoventilation as well. But that's not the only problem they have. So if you have a patient that has hypoxemia and the PCO2 is elevated, you know there's hypoventilation present, but you have to see if there's another cause of hypoxemia present. And how will you do that? Say it again?
Anion gap.
No, not the anion gap. No, but stuff we already talked about today. The AA gradient. You calculate the AA gradient. Because if the AA gradient is increased, then what do you conclude? That's what? There has to be another cause. Because why is that? Right, if it's just hypoventilation and you calculate the AA gradient should be normal. So if you have a patient that's hypoxemic, and you look at the PCO2 and say it's elevated, okay, they're hypoventilating, you calculate the AA gradient, and the AA gradient is normal, then you're satisfied that, okay, this person is just hypoventilating, okay? If you have somebody that is hypoxemic and hypercarbic, the CO2 is increased, you calculate the AA gradient, and the AA gradient is increased, then you know, okay, they're hypoventilating, but there's something else going on too. All right, everybody see that? What if you check the CO2 and the CO2 is not elevated? Okay. Well, then you know that you're not dealing with hypoventilation, right? You're dealing with some other cause of the hypoxemia, and so you're going to go then straight away to calculate the AA gradient. Okay. If the AA gradient is normal, if the AA gradient is normal in a patient who is hypoxic, the PCO2 is normal, then what are the possibilities? What do you think? I gave you the list of 6 things that can cause it. AA gradient is normal, PCO2 is normal, but they're hypoxic. Huh? Right, so you either, this is one of those people that you put into a room and are sucking the oxygen out of it, right? Or they're at altitude, right? They're at altitude. Because the partial pressure of oxygen is going to be lower at altitude, okay? Suppose you have somebody, they're hypoxic, you check the AA gradient, and the AA gradient is elevated. PCO2 is normal, they're hypoxic, PCO2 is normal, AA gradient is elevated. Okay? Now you're dealing with one of those other causes of hypoxemia. You could be dealing with a shunt. And the big thing that you're going to have to distinguish is, are you dealing with a shunt or are you dealing with a VQ mismatch? Those are the 2 things that you're going to want to distinguish clinically. And the way you distinguish them, okay, the way you distinguish them is by putting them on supplemental oxygen. You increase the FiO2, okay? If somebody has a VQ mismatch, all right, then their hypoxemia is correctable with supplemental oxygen. If they have a shunt, I showed you a picture of a shunt. I'll go back and show you a picture of the shunt again. But if you're dealing with a shunt situation, then the PO2 is not correctable with oxygen. Okay. Some of the clinical conditions that can be associated with a shunt include atelectasis, intraalveolar filling, like from pneumonia, consolidated pneumonia, or pulmonary edema. Obviously, an intracardiac shunt that we talked about in the last module. Remember the intracardiac shunts that you can have. So if you have a shunt that's going to cause deoxygenated blood to go to the systemic circulation, that would be an example of that. But you can have a shunt within the lungs as well, an intrapulmonary shunt. It doesn't have to be an intracardiac shunt. As opposed to shunts, VQ mismatch, things that can cause VQ mismatch include obstructive lung disease, so like COPD or asthma, interstitial lung disease, certain types of pulmonary vascular disease, all right, so any questions so far about the causes of hypoxemia, about how to approach the patient that has hypoxemia, how to think about the patient that has hypoxemia, how to calculate the AA gradient, or how to determine if a particular patient has an AA gradient that is acceptable or not? Any questions about anything that we talked about so far? Yeah.
If someone has a small region of atelectasis, but the rest of the lungs are working, and you
No,
test them on
it's,
those two,
yeah. I mean, you're talking about it's got to be. It would have to be a significant, because people can develop a small amount of atelectasis, tiny amount of atelectasis. But whether it's going to be clinically significant or not is going to depend on the amount of the size of the atelectatic area, because it could be dwarfed by the size of normally functioning lung.
thank you.
Okay. So they in figure 2.1, they give you a couple of different examples of some of the things that we've talked about. So for example, B, the alveoli filled with fluid or blood or pus, that would be, again, an example of something that would produce a shunt situation. It's basically the equivalent of that. Whether you block the airway or you occlude the lumen of the alveolus, it's going to have the same physiologic effect, okay? We'll talk about C as restrictive lung disease. We're going to talk about that when we in a little while. But restrictive lung disease can produce a VQ mismatch. It's an example of interstitial lung disease, and so it can produce a VQ mismatch, as I've already said. It can also produce diffusion abnormalities, okay, which is another mechanism of hypoxemia, which we talked about. Again, obstructive lung disease can produce the VQ mismatch, as we just said. Again, that's not, if it's a complete obstruction, you're dealing with a shunt, but if it's short of that, then you're going to get a VQ mismatch. And of course, E, we're talking about dead space again. That's the pulmonary embolism type situation. Okay, I want to bring your attention to a couple of the things that are discussed in the book. Highlight a couple of things. So, for example, when they discuss 2.1 on page 36, they discuss the figure. They talk about some examples of processes that can cause that picture. They mention cardiogenic pulmonary edema. They mention non-cardiogenic pulmonary edema, or ARDS. They also mention that if you get pulmonary hemorrhage, that blood can fill the alveolus as well, and that can produce the clinical picture associated with panel B. And they give you as an example of that Goodpasture syndrome. And you remember I told you when we talked about the vasculitides, and we talked about something called Wegener's granulomatosis or midline granulomatosis. Remember I told you that there's you'll see pulmonary and renal disease in patients that have midline granulomatosis, but that you can see that in other conditions as well. Goodpasture syndrome is such a condition. These patients develop a pulmonary hemorrhage, but it's also associated with it's also referred to as anti-glomerular basement membrane disease, because that's the pathogenesis of it. There's an antibody to the glomerular basement membrane, and so besides having the pulmonary hemorrhage, they can develop rapidly progressive glomerulonephritis. So pulmonary hemorrhage and rapidly progressive glomerulonephritis, you think about Goodpasture syndrome. Okay. All right. In terms of let's talk about 21. Okay, in 21C and D, they're discussing restrictive lung disease and obstructive lung disease, and we're going to talk about them in a second, so I'm not going to discuss it at length here. One of the things that they don't make clear in Figure 2.1 is that you can also have diffusion abnormalities that can cause hypoxemia. I did mention that. Just a couple of things to note about that, okay? Here's the exchange of gases at the level of the alveolus where it abuts the pulmonary capillary. So oxygen enters the bloodstream, CO2 enters the alveolus, and then is expired. Here's mixed venous blood coming in, and then this is oxygenated blood returning to the left heart, okay? Now normally, CO2 exchange is perfusion limited. What that means is that the more blood you bring to this point, the more CO2 goes into the capillary, goes into the alveolus, okay? And it'll basically go until the concentrations are going to be the same on both sides, okay? So it's perfusion limited. Normally, in the normal situation, oxygen is also perfusion limited, which means oxygen diffusion, which means that the more blood you bring to this point, the more oxygen is going to enter the capillary, okay? You bring blood to this point, the oxygen is going to enter, okay? But sometimes oxygen exchange is not perfusion limited, but it's diffusion limited. And there's two situations when oxygen exchange is diffusion limited. When it's limited by how fast this process can take place. Okay, so this is normally so fast that it's just a question of how much blood do we have here, okay? But sometimes it's diffusion limited. This is the rate limiting step, and it's two circumstances. First of all, with extreme exercise, so if a person is exerting themselves, oxygen transfer, oxygen diffusion can become diffusion limited as opposed to perfusion limited. And secondly, if the person has fibrotic lung disease. So if you thicken this membrane here, and you make it harder, if the oxygen has to go further, has to diffuse further, okay? then that process can become rate limiting. So this is why people complain of shortness of breath when they exercise, and particularly patients that have, you know, fibrotic lung disease when they exercise. Yeah.
You also have a pulmonary.
Anything that thickens that membrane. Yeah. All right. And this is going to show you some of the changes in, so this is mixed venous, the partial pressure of oxygen in the mixed venous blood, the partial pressure of CO2 in the mixed venous blood, and it shows you, this is what the alveolar contents are, and this shows you the change after the blood goes through that alveolar capillary unit. And this again shows you the difference between a diffusion limited process of exchange and a perfusion limited process of exchange using two different gases. I'm showing you how these two different gases behave differently. So just to try and, again, we want to think back to some of the stuff that we've already talked about. We did talk about exertional dyspnea before when we talked about the heart. Remember we said you can get dyspnea on exertion in patients that have what? What kind of heart disease? What kind of cardiac disease can produce dyspnea on exertion? Huh? Say it again?
Aortic stenosis.
Well, okay, so if they have aortic stenosis, they can get dyspnea on exertion. Sure, that's true. What else? Heart failure, okay. So basically, myocardial ischemia or myocardial dysfunction, okay, systolic dysfunction or diastolic dysfunction, those things can produce dyspnea on exertion. So now you have something else that can produce dyspnea on exertion, which is pulmonary disease. Okay, so pulmonary disease, cardiac disease, certainly since we're talking about oxygen and oxygen transfer, if somebody is anemic and they're not capable, they don't have the corpuscles to carry the oxygen, that can produce dyspnea on exertion as well. All right. The next thing that they talk about is the pulmonary vasculature. And we've alluded to this before when we talked about dead space. We talked about dead space, and we said that that can happen in the setting of a pulmonary embolism. So that pulmonary embolism is going to produce hypoxemia by that mechanism. They talk about the relationship between. Well, actually, they don't talk about the relationship between it. They talk about pulmonary hypertension as another disease of the pulmonary blood vessels. But you can develop pulmonary hypertension from pulmonary embolism. You can have primary pulmonary hypertension, which have you studied pulmonology in clinical medicine and surgery? Did you talk about primary pulmonary hypertension? So you know the difference between primary pulmonary hypertension and secondary pulmonary hypertension. Patients that have secondary pulmonary hypertension, usually they have it on the basis of hypoxemia. Okay. So, but okay, you can also get pulmonary hypertension from pulmonary embolism and certainly from repeated episodes of pulmonary embolism. Okay, let's turn our attention to obstructive and restrictive lung disease, and we're going to talk first about obstructive lung disease. So the first, there's a number of diseases that are obstructive lung disease. There's emphysema, chronic bronchitis, asthma, cystic fibrosis. These are all considered obstructive lung diseases. So let's talk first about emphysema. Patients with emphysema are sometimes referred to as pink puffers, and they're referred to as pink puffers because they're less hypoxemic than patients that have chronic bronchitis, which is, you can think of COPD, including emphysema and bronchitis, at opposite ends of the spectrum, okay? So the patients that are pure purely emphysematous, they're pink puffers, they're less hypoxemic, and they're not hypercarbic. They tend not to be hypercarbic, okay? The alveoli that they have have decreased elastic recoil, and as a result of that, the bronchioles are more likely to collapse. Okay, so what you have here is, if you think about the chest wall and the lungs together, okay, the lungs, if they had their druthers, okay, compared to, just think of yourself in a normal resting position. Neither, you're just resting without either inspiring or expiring. You're just in your normal resting state, okay? The lungs in vivo are going to be bigger than they would like to be. Okay, if you open the chest wall, the lungs collapse, right? And you do an autopsy or whatever, and you crack the chest, the lungs tend to collapse. So that's going to be the normal elastic recoil is going to tend to collapse the lungs. Okay, the chest wall, okay, is going to tend to expand if it didn't have the elastic recoil of the lungs pulling it in. So the chest wall wants to go boing, right, and the lungs want to collapse. Okay, so these forces are acting in opposite directions and sort of holding each other in check. Okay, so here is the normal situation, and you have the elastic recoil of the elastic recoil of the lungs is going to tending to push in this direction. Okay, and the chest wall is going to tend to pull out. Okay, now when they're showing you this number here, they're showing in forced expiration, okay, because if you compare it to the one that's over here, okay, here's rest, so we're talking about forced expiration, okay. Now you have a positive intrathoracic pressure as you generate an expiratory force, okay. So now what's happening is you have the positive intrapleural pressure from that expiratory effort. You add that to the elastic recoil of the lungs. Both of those forces are going to tend to collapse. The lungs. You everybody see that? Okay. And of course, this pressure is going to be shared throughout the pleural space. Okay. What happens is that the only thing that gets air to move from the alveolus to the mouth is the pressure difference between here and there, okay? So as long as the pressure here is greater than there, air is going to move in that direction. And as long as the pressure is greater here than there, it's going to tend to move in that direction. It's pretty simple. So what they're showing you is that in a patient that has chronic obstructive pulmonary disease, okay, the elastic recoil of the lung is less. The elastic recoil of the lung is less. The tendency to collapse the lungs is less. What that results in is less of a driving force between here and there. Okay? Now, the intrapleural pressure with expiration, you see, is going to be the same. Okay? But at some point in time, and you see the pressure decreases from here to there because of resistance along the way. That's why the pressure is going down, resistance to airflow. And what's going to happen is that when the when the loss of the elastic recoil becomes severe enough, then at some point in time during forced expiration, the airways tend to collapse. And you get obstruction. And so you get air trapping in the lungs. And that's what's going on with patients that have emphysema and chronic bronchitis, especially emphysema and also chronic bronchitis. So you get air trapping in the lungs for this reason. If you think about it from a okay, think about this as a well, they're showing an alveolus, but think about this as being an airway. Let's make believe that this is an airway instead, okay? One of the things that holds the airway open in the lungs is that it's tethered to surrounding tissues, to surrounding airway, okay? Think of sort of a honeycomb type situation. Well, as those tethers are destroyed by the emphysematous process, and you get destruction of lung tissue, then their tethering forces are lost. They don't hold that lumen open. And so that lumen is going to tend to collapse here. Okay? Everybody see that? Everybody see where you get airway collapse in COPD? But again, the thing to keep in mind is that you're losing, it's exerting its effect at the level of the elastic recoil of the lungs. It decreases that, and so it decreases the driving force. Okay, so they talk about some of the signs and symptoms of emphysema. They talk about the prolonged expiratory phase. They talk about the use of accessory muscles to help exhale. They talk about wheezing on exam. These patients also often breathe through pursed lips. So if you ever watch patients that have obstructive lung disease breathe, they often purse their lips during expiration. So they'll breathe like this. What that does when they purse their lips and they expire through their mouth is they're increasing the resistance here at the mouth. Okay, so they want to raise the resistance here compared to there to keep this area open. Okay, it tends to, the resistance here, increasing the resistance here tends to open this area. So that's why they breathe through pursed lips. Patients that have COPD, including emphysema, they as the book makes clear, they breathe at high lung volumes. You remember that from radiology, right? This summer, you remember that, and you remember that they have. You can count the number of ribs, and that's often flattening of the diaphragms, and those are often signs of patients with COPD. Okay, in terms of pulmonary function testing. In terms of pulmonary function testing, the hallmark of patients with COPD, particularly emphysema, is the FEV1-FVC ratio, and they depict it in Figure 2.2 at the bottom of page 38. So you see that you see a marked decrease in the FEV1, and the forced vital capacity. It changes, but changes less, or it may change. It may stay the same. But in any event, the net effect of that, the change in the numerator and the denominator, is that you get a fall in the FEV1 to FVC ratio, the ratio of this to that. Here's normal situation. Here's obstructive situation, obstructive lung disease. And then you're going to see that in any obstructive lung disease, asthma, emphysema, chronic bronchitis, cystic fibrosis, bronchiectasis, whatever. Now, the one way you can distinguish between the different types of obstructive lung disease, of course, if it's asthma, it's reversible, so that you can distinguish clinically, okay? But if, let's say you want to distinguish, is the patient I'm dealing with, is he or she predominantly at an emphysematous type or a chronic bronchitic type, you can distinguish between them by looking at the diffusion capacity. So because in emphysema, the pathophysiology involves destruction of alveolar walls and destruction of lung tissue, then the diffusion is going to be impaired. So you can measure the diffusion of carbon monoxide, and the diffusion of carbon monoxide is going to be impaired in patients with, that's the DLCO, and it's going to be impaired in patients that have emphysema, and patients that have chronic bronchitis, not so much. Okay, the second major type of COPD is chronic bronchitis. And this just illustrates the bronchial wall anatomy and some of the changes that you can see in patients that have chronic bronchitis. In chronic bronchitis, again, the pathogenesis is going to involve obstruction of the airways with mucus that increases resistance to airflow. It's defined clinically as sputum production for more than 3 months in each of the previous 2 years. So if the patient's producing sputum for more than 3 months in each of the previous 2 years, then that's consistent with chronic bronchitis. These people are referred to clinically as blue bloaters as opposed to pink puffers. They are more hypoxemic than patients with emphysema, and they are hypercarbic. The PFTs are going to show the same fall in the FEV1 to the FVC ratio. By the way, I didn't explain these terms, but I'm assuming you talked about these in physiology, right? This is the amount of air that you can force to expiratory body, what you do in 1 second, and this is what you do at the end of the respiration. This is the total amount that you expire. So I'm assuming you got that in physiology. So that's going to be unchanged. It's going to be essentially the same. You see the same type of picture in patients with chronic bronchitis that you see in emphysema. But again, one of the things that you can use to distinguish them is these patients, to the extent that they have pure chronic bronchitis, are going to have a normal diffusion capacity or preserved diffusion capacity, whereas patients with emphysema, pure emphysema, they have a fall in the diffusion capacity. And usually patients are either purely emphysematous or purely chronic bronchitis. They have components of each. Okay, they can exist anywhere along the continuum. Okay, any questions about emphysema or chronic bronchitis? What we'll do is let's come back at 5 after, and we'll resume.